Okay, if you're getting close to finishing med school, you know that medicine is all about playing the odds, right? But how do you actually take all those stats and turn them into a real confident decision at the bedside? Well, that's what we're going to break down right now. We're going to turn these kind of abstract numbers into practical, everyday tools. So here's the game plan. We're going to start with the most fundamental question of all. Should you even order a test in the first place? From there, we'll build everything up from the ground floor, starting with a super simple 2x2 table, then we'll get into some more advanced tools, and finally, we'll put it all together with a real-world clinical case. Let's dive in. All right, first things first. Before you even think about ordering a test, you have to ask yourself a really important question. Will the result, no matter what it says, actually change what I do for this patient? And that's where this idea of the diagnostic threshold model comes into play. Let's just be real for a second. When is ordering a test a total waste of time, money, and your patient's comfort? Well, the answer really boils down to your pre-test probability. That's your gut feeling, your suspicion of the disease before you've even ordered anything. Think of it like this. This model shows your level of clinical certainty. Way over on the left, the chance of the disease is so low that a test isn't going to change your mind. And way over on the right, it's so high that you just go straight to treatment anyway. The real magic, the sweet spot for testing, is right there in the middle zone of uncertainty. So here's the key takeaway. Below that test threshold, you're already pretty sure the result will be negative, so why bother testing? And once you're above the treatment threshold, you're basically certain you have the diagnosis, so it's time to act. Testing is only truly valuable when you're caught in that middle ground of diagnostic uncertainty. All right, so let's say your patient lands squarely in that we should probably test zone. How do we figure out if the test itself is any good? Well, the foundation for absolutely everything that comes next is a simple but incredibly powerful tool, the 2x2 table. You're going to see this table a lot. It's the bedrock. All it does is compare the test result against the truth, what we call the gold standard, and that creates 4 possible outcomes. If you can understand these 4 boxes, you can understand everything else. First up, the true positive. This is the ideal scenario, right? The patient is sick and our test nails it. It correctly flags the disease. This is our target. Next, the false positive. This is when a healthy patient gets a positive result. And this isn't harmless. It leads to a ton of unnecessary anxiety, more tests, more procedures. It's a costly mistake. Then you've got maybe the most dangerous box of all, the false negative. This is when a sick patient is told they're perfectly fine. It gives them false reassurance and can delay critical treatment. This is a big deal. And finally, the true negative. The patient is healthy and the test confirms it. You get to give them accurate peace of mind. So those are our 4 outcomes: true positive, false negative, and true negative. They are the building blocks for everything. Okay, now that we have our building blocks, we can actually start to calculate the 2 fundamental characteristics of any diagnostic test: its sensitivity and its specificity. These numbers are baked into the test itself. They don't change depending on the patient. So, sensitivity. It answers a really straightforward question. Of all the people who actually have this disease, what percentage does our test correctly pick up? You can think of it as the test's ability to sense that the condition is there. A test with high sensitivity is kind of like casting a really wide net. The whole point is to catch every single person who has the disease. Yeah, you might accidentally pull in a few things you weren't looking for, some false positives, but you make sure no true cases get messed. And this brings us to one of the most useful mnemonics you'll ever learn: SNOUT. A test with high sensitivity, when it comes back negative, is fantastic at ruling out the disease. It makes sense, right? If you cast that huge, wide net and it comes up totally empty, you can be pretty darn confident there was nothing there to catch. Now, on the flip side, we have specificity. This answers the other important question. Of all the people who are perfectly healthy, what percentage does this test correctly clear? It's all about being specific to the disease and not accidentally flagging healthy people. So if a sensitive test is a wide net, a highly specific test is more like a precision surgical tool. It's designed to only target the one thing it's looking for, correctly identifying everyone who doesn't have the condition, and avoiding all those stressful, costly false positives. And you guessed it, here's the partner mnemonic: SPIN. A test with high specificity, when it gives you a positive result, is excellent for ruling in the disease. If that super precise tool gives you a positive signal, you can be very confident that you found exactly what you were looking for. Okay, sensitivity and specificity are great. They describe the test itself. But let's be honest, your patient doesn't really care about that. They have one simple question. Doc, what does this result actually mean for me? And that's where predictive values come in. And this gets us to predictive values. The positive predictive value, or PPV, it answers the patient's question, okay, my test is positive, what's the actual chance I have the disease? And the negative predictive value, or NPV, answers, my test is negative, what's the chance I'm really in the clear? But, and this is a huge but, unlike sensitivity and specificity, these values are massively influenced by how common the disease is in the group of people you're testing. So, if predictive values can be a little shaky because they depend on prevalence, is there a better tool, a more stable one? You bet. Let's look at two more advanced concepts that give you a much more solid way to interpret test results: likelihood ratios and ROC curves. Likelihood ratios are awesome. They're incredibly powerful. What they do is tell you how much a test result should shift your suspicion. So, how many times more likely is a positive result in a sick person than in a healthy one? And the best part is, they are not dependent on prevalence, which means you can apply them to any individual patient. An nomogram is basically a clinical cheat sheet for using these likelihood ratios. It's super simple. You find your pretest probability on the left, you draw a straight line through the likelihood ratio of your test in the middle, and bam, it points you directly to your new post-test probability on the right. It's such a quick way to see exactly how much that test result should change your thinking. Finally, what if you're trying to compare a few different tests? How do you know which one is best overall? You use a receiver operating characteristic, or ROC curve. It just plots the true positives against the false positives. Look, a useless test is just this diagonal line. It's no better than flipping a coin. A good test, a useful test, bows up towards that top left corner. And a theoretically perfect test would make a sharp right angle. Basically, the more area under that curve, the better the test is overall. Okay, that's a lot of theory. It's great, but let's make it real. We're going to take everything we just talked about and apply it to a quick clinical example, using the anterior drawer test to see if someone has a ligament rupture. Here's our 2x2 table from a study that was done. We can see we have 90 true positives, 9 false positives, 27 false negatives, and 28 true negatives. Okay, got the numbers, now let's run them. So when we crunch the numbers, we get a sensitivity and specificity in the mid-70s. You know, they're decent, but not amazing. But now look at the predictive values. The PPV is really high, 91%. That means a positive test is actually pretty trustworthy. But the NPV, it's only 51%. That's basically a coin flip. A negative test here doesn't really tell you much at all. And the positive LR of about 3 tells us a positive result does moderately increase our suspicion of a rupture. So let's put it all together. You have to ask yourself, based on these numbers, is this test better for ruling a condition in or for ruling it out? Well, with that higher specificity and that much stronger PPV, it's way more useful for confirming your suspicion than it is for telling a patient they're in the clear. It's a classic spin test. And making that choice, knowing a test's strengths and weaknesses and when to use it, that is what clinical appraisal is all about.